Most people think of allergies as annoying inconveniences. Maybe you get a rash, your eyes itch, you swell up a little, and you take some medicine and sooner or later it passes. But in anesthesia, there are a couple of what I like to call genetic allergies that are not annoying at all. They sit quietly in your DNA for your entire life, causing zero problems, until the one day you go to sleep for surgery, we give you a perfectly standard drug at a perfectly reasonable dose, and your body suddenly goes off like a grenade. Your heart rate shoots through the roof, your muscles lock up like you've been encased in concrete, your temperature starts rising, and your organs can begin to fail within minutes. Today, I want to show you these hidden anesthesia time bombs, how we catch them, and what really happens in the operating room when they go off. It's another routine day for you as an anesthesiologist. Your next patient is young and healthy, they have no significant medical history, and nothing exciting in the chart, which is just the way we like it. You go out to the pre-op area to meet them, and you ask if they have any medication allergies. They say, "Nope, I've never had a problem with any medicine. I've never even had surgery before." A few minutes later, you bring them back to the operating room and go through the standard patient checks with the OR team. They move over to the operating table, you give them a mask with some oxygen and tell them to take some nice deep breaths. Then you give them the anesthesia, place the breathing tube with no problem, and everything's looking beautiful. Soon the surgeon gets started and the vibe in the room is pretty relaxed. But about 20 minutes into the case, you notice something on the monitor. The carbon dioxide number, the one that tells you how much CO2 the patient is breathing out, has started climbing a tiny bit. So you make a small adjustment to the ventilator, but it keeps climbing anyway. You look up a little higher and now the heart rate has started to climb too, and so has the blood pressure. The patient, who should be completely relaxed by the anesthetic, feels rigid when you try to move their jaw. Then you notice that the patient's body temperature is also higher than normal. Suspicious of a monitor malfunction, you place a temperature sticker on the patient's forehead for a second opinion, but that one's even higher than the other one. So you get another reading with a different thermometer and realize that the body temperature really is rising fast. In a matter of minutes, this easy case now looks like something a lot more serious. The surgeon is still happily working. To them, the case looks normal, but from the head of the bed, from the anesthesia side, you're watching the early signs of a rare genetic disaster unfolding. What I just described is the beginning of something called malignant hyperthermia. Malignant is a medical term meaning severe or life-threatening, and hyperthermia means high temperature. And that pretty much describes what happens with malignant hyperthermia. There are no hives, no itchy eyes, no runny nose, so it's not technically an allergy in the usual sense. It's actually an inherited disorder that affects the way your muscle cells handle calcium. Most of the time, that problem never shows itself. Most people go their entire lives without knowing they even have it. The crazy thing is that, as far as we know, only two kinds of drugs can trigger it, and they're both things that are pretty much only used in anesthesia. Volatile anesthetics like desflurane or sevoflurane, and depolarizing muscle relaxants like succinylcholine. In people with malignant hyperthermia, these drugs can set off a chain reaction that goes like this. Inside each of your muscle cells, there's an organelle called the sarcoplasmic reticulum, which is very pleasing to say for some reason. Sarcoplasmic reticulum. Sarcoplasmic reticulum. Sarcoplasmic reticulum. It's like an alien being or something. The sarcoplasmic reticulum acts like a bunch of tiny storage rooms filled with calcium, which is the signal that tells muscles to tighten. On each of these storage rooms, there's a special door called RYR1. When your body wants a muscle to move, this door opens and lets calcium rush out into the cell so the muscle can tighten. Then the door closes again so the muscle can relax. In people with malignant hyperthermia, the RYR1 door is built wrong because of a genetic mutation. When we give volatile anesthetics or succinylcholine during surgery, these broken doors suddenly start opening on their own, and then they become really hard to close again. That means millions and millions of calcium atoms start spilling out into the muscle. The muscle then works overtime trying to pump all that extra calcium back into the storage room. But it's no use because the RYR1 doors are malfunctioning, so the calcium just continues to spill out. These pumps that are trying to get all this calcium back into the storage rooms use up an enormous amount of energy, and your body responds to this by ramping up metabolism, which generates a huge amount of heat and makes your temperature rise dangerously high. It's like every muscle in your body suddenly stomped on the gas pedal at the same time, and now the engine is redlining and getting dangerously close to catastrophic failure. Now, from my point of view as an anesthesiologist, this chain reaction doesn't start with a giant flashing malignant hyperthermia sign. It starts with subtle changes on the monitors. The carbon dioxide level that keeps drifting up no matter how much I adjust the ventilator. The heart rate that's out of proportion to what's happening in the surgery. Muscles that feel unusually stiff, and a body temperature that's climbing in a way that just doesn't make any sense. But I can't afford to just sit there and watch it unfold like a slow-motion train wreck. If this is malignant hyperthermia, literally every minute matters. So at some point very early on, I need to make a decision and say out loud, I think this is malignant hyperthermia. We need to start treating it right now. When that happens, the energy in the room changes immediately. The surgeon stops what they're doing. The OR nurse calls for the malignant hyperthermia cart. I call the OR front desk and ask them to send in some people to help. Someone else grabs a bunch of ice and cooling supplies. Another person starts looking for extra IV access. The anesthetic gases that might be triggering this are turned off, and we switch to pure oxygen. We change the ventilator settings to try and blow off some of that excess carbon dioxide, and we start actively cooling the patient's body down. All of that is extremely important, but I haven't told you about the star of the show yet. That's a drug called dantrolene, the antidote to malignant hyperthermia. Remember how I said that during a malignant hyperthermia episode, calcium is pouring out inside the muscle cells and pushing them into overdrive because of that broken RYR1 door? Well, dantrolene works at the level of the muscle cell to basically help slam all of those trillions of little RYR1 doors shut. The big problem with dantrolene, though, is that it doesn't come pre-mixed and ready to go like most medications in the operating room. It usually comes as a powder that we have to mix with sterile fluid before we can inject it into the patient. And it's not just one little vial and boom, you're done. It's a lot. I'm talking about opening and mixing vial after vial after vial, while also trying to manage the rest of the chaos that's happening in the room at the same time. That's why malignant hyperthermia carts are stocked in advance, and why OR teams practice dealing with malignant hyperthermia in simulated scenarios. When the anesthesiologist calls this, you need people to know exactly where to stand and exactly what to do without small talk or confusion or any bullshit. So just imagine this scenario for a moment. The patient's on the table, sweating like crazy with stiff muscles. The surgeon is standing still with their hands out, unable to do anything but watch the chaos unfolding around them. One nurse is at the head of the bed helping you, another is at the side table snapping open vials and shaking them as fast as possible. A team of OR nurses are packing ice all around the patient's body. The anesthesia machine alarms are beeping and sounding, and there's no jokes and no music. Just people speaking clearly and loudly and trying to keep this patient from overheating to death. That's malignant hyperthermia when it explodes in real life. It's dramatic and it's dangerous, but thankfully it's also extremely rare. Most anesthesiologists will go their entire careers without seeing one single case. But we all train for it because when it does happen, we need to be prepared to start treating it with no delays or hesitation. Now that's one kind of hidden anesthesia time bomb, but there is another one, and it's completely different. Instead of ramping up your metabolism and causing you to dangerously overheat, this one can lead to your whole body being paralyzed for hours, sometimes even days. Succinylcholine is a medication that we use in anesthesia to temporarily stop muscle movement. We often use it after we put you to sleep to help relax your muscles really quickly when we're trying to place a breathing tube. We don't want you coughing or gagging or biting down on any of our metal instruments and damaging your teeth or biting your tongue. In most people, this drug is broken down by an enzyme in the blood called pseudocholinesterase. And because it works so fast, the paralysis usually only lasts a few minutes. But not everyone has the exact same version of that enzyme. Some unlucky people inherit a variant that isn't very good at breaking down succinylcholine. This is called a pseudocholinesterase deficiency. The exact same dose that paralyzes most people's muscles for a couple of minutes can leave them paralyzed for way longer. Think like several hours to potentially several days. Now, when you're fully asleep under anesthesia, lying there on a ventilator, that longer paralysis isn't really life-threatening. We can keep you asleep, keep breathing for you, and just wait it out. You're not aware of any of this happening, you just spend more time knocked out under anesthesia. The thing people fear, and the thing we work really hard to avoid, is a mismatch between paralysis and unconsciousness. The horror scenario in online comments is usually something like, "What if I'm completely awake on the operating table but I can't move or breathe?" That's the nightmare people imagine, and if you understand what a pseudocholinesterase deficiency does, it's not too hard to see where that fear comes from. Succinylcholine doesn't affect your thoughts or consciousness at all. It only affects muscles. So if the muscle paralyzer were to outlast the anesthesia, in theory you could have completely normal awareness but with no ability to move. In real practice, our job is to prevent that situation at all costs. We continuously monitor your depth of anesthesia. We monitor how well your muscles are working with nerve stimulators, and we definitely don't just assume that everyone recovers at the same speed. If a patient is taking a long time to move or breathe on their own, we keep them sedated, we keep breathing for them, and we just wait until we can get some evidence that they truly have their muscle strength back. Because pseudocholinesterase deficiencies only affect a tiny handful of drugs, mostly succinylcholine, they almost always come to light because someone at some point stayed paralyzed far longer than expected after a surgery. They wake up hours later in the intensive care unit or recovery area and someone says, "You had a very unusual reaction to this medicine. We think you have this enzyme deficiency." Then that gets written in their chart, and ideally it follows them forever, so the next anesthesiologist can see it and make plans to work around it. So now that you know about these two conditions, malignant hyperthermia and pseudocholinesterase deficiency, you might be wondering, can I know ahead of time if I have one of these genetic traps? Well, sometimes the answer is yes, but you have to help. When I go and meet you before surgery, I'm not just making small talk when I ask if you've ever had any trouble with anesthesia. What I'm actually doing is fishing for clues. Has anyone in your family ever had a really bad reaction in the operating room? Has anyone overheated during surgery? Did anyone die in surgery without a clear cause? Has anyone needed to stay on a breathing machine for hours after a short procedure because they wouldn't wake up or couldn't move? Those stories may sound vague to you, but to me they're huge red flags. If someone tells me, "My uncle had to be packed in ice in the operating room because he sweats so much," or "My sister's so lazy, it takes her like 4 days to wake up from anesthesia," I start thinking very carefully about malignant hyperthermia and pseudocholinesterase deficiency. I might choose to use drugs that can't trigger malignant hyperthermia. I'll almost certainly avoid succinylcholine completely. And I might even order some extra tests or talk with a specialist about it. Scientists have developed specific tests and genetic panels that can confirm a person's risk of malignant hyperthermia, especially in families where someone has already had a crisis. Most people don't need this kind of testing, but if your family has a history of mysterious anesthesia disasters, it's absolutely worth bringing that up to your doctor before the surgery. Please don't wait until after. Now let me put this in perspective because I know this video is probably making some of you nervous. Yes, there are rare genetic conditions that can turn a routine anesthetic into a critical care scenario in no time. That's just part of the reality of medicine. But the other part of the reality is this. We know about them. We train for them. We stock the antidotes. We develop protocols and drills so that if this ever happens once in a career, the team is ready for that one moment. And remember, the reason I'm even telling you these stories is not to make anesthesia sound like some kind of wild gamble. It's to show you that anesthesiologists and nurse anesthetists are obsessed with safety. We spend a lot of time thinking about the disasters that almost never happen, so that for you, getting anesthesia is freaking boring. And if someone in your family has ever said, "Oh, I had a horrible time with anesthesia," or "Your cousin almost died on the operating table 30 years ago," don't let them stay as vague, scary stories forever. Ask what actually happened. Write it down. Bring it up to your anesthesia team next time you're scheduled for a procedure. That information can literally change how we plan your care and keep you safe. If you've ever had a weird experience with anesthesia, or a family member who had a dramatic reaction, please tell me the story in the comments. I always read them, and I might break a few of them down in a future video to explain what was probably going on behind the scenes. And the next time you find yourself on an operating table, remember that there's someone at the head of the bed whose full-time job is to watch for exactly these hidden dangers so that you never even have to think about it. Thanks for watching, and I'll see you in the next one.